Thank you for coming out this afternoon. I just saw Dr. Levine walk in. I'll just wait for him. There's Dr. Levine. No, we're just waiting for you to start. Okay, so the topic I picked up for the grand rounds today is a topic that is really relevant to each one of us, irrespective of which subspecialty we have, which clinic that we work at, because we see a hypertension patient in the hospital, in the clinic, every day. And perhaps 1/3 of us in this room, we're all above 18, are likely to be hypertensives. And the story of hypertension has gone through a lot of changes from the point in 1930s when we considered it a sin to actually treat somebody with hypertension. And hypertension was an essential change in the body, and that was required to perfuse the body organs. And in understanding the physiology of it and understanding the pathology associated of it took several decades. And it wasn't until 1970s, after a lot of morbidity and mortality, that the first clinical trials came out which clearly showed a benefit of treating hypertension. And from 70s onwards, when the trials first started, we had maybe a handful of 10, 15 drugs for treating hypertension. And one of the mainline drug at that time was hydrochlorothiazide. And then we had Recipine and some of the other medications. And propranolol was the first beta blocker that was introduced. We've come a long way to having over 100 medications available to us to treat high blood pressure. And that has really helped to get some of those patients who've been difficult to control in target. But it's also led to a lot of confusion about what is the best way to manage somebody with an elevated blood pressure. And we've always looked up to government agencies and the Joint National Commission, or the JNC, to help us guide towards a better blood pressure target and a better blood pressure control. And every few years, the guidelines have shifted some, and there was a new guideline, the JNC 8, that just came out in December of last year. And I'm going to focus on that guideline because it has raised a few questions about what we have been doing for the last 10 years. Ever since I started training in the United States, I always heard certain goals and certain blood pressure management strategies, and it's put into question as to, do we really know what we are doing? So the very first thing that I put out, the biggest risk for somebody with hypertension is for diagnosis. Does that still hold true? So we know from the biggest, the enhanced data and the Framingham Heart Study have shown the prevalence of hypertension to be widespread. And the prevalence is variable across the world, and it does vary with countries, the developed nations, and the high salt intake does increase your risk. But one of the biggest risk factors is age, which is not modifiable. And aging does increase your risk. So if you take into account the total number of population, we've got about 29% of the total population as of 2012 survey in the United States that has hypertension, so 1 in 3, and that's up to 60 million people in our country. So it's a big chunk of population. And despite knowing, and we've gone, as I said, a long way from 1930s to now, where we know the risks, and each one of us has been very clearly told about those in our training. The awareness of hypertension has gone up from early 70s up, from about 50% of the people who actually had hypertension and were aware of it, to upwards of 79 in the 2010 survey. And the treatment is in about 2/3 of those who are aware of it are being treated. And the control of those being treated is only in about 50%. And we look at what's going on in 2012, the numbers just slightly get better, but what we still only about 50% of the patients who know that they have hypertension and are getting treated are in control. So there's clearly a lot of room for improvement. When if you break it down by age groups in the 2012 enhanced study, they looked at the younger age group population. Only about 40% of those who are aware that who have hypertension are actually being treated. And we know that the younger you are and you do not treat the hypertension, the more likely you're going to develop the long-term sequelae of that disease. So the 60-year-old and over are getting treated 82% of the times, whereas the younger population is not getting treated as well. There's a little bit of difference between men and women, but it's not really that big. But yet, less men elect to get treatment even after they're aware of their hypertension. So what have the guidelines been saying? And every year we've had a host of guidelines because we have multiple societies who have vested interest in controlling hypertension. The American Society of Hypertension, the ASH, they came up with a very extensive guideline statement, almost a huge document, which goes over the entire dietary modifications along with pharmacological treatment and diagnosis of hypertension. It's a wholesome document. The 2013 European Society of Hypertension came up with their own guidelines, and then the JNC 8, which has always guided the treatment of hypertension in the United States, came up with their own revised guidelines in 2014. The last guideline from JNC 7 was in 2003. So this was well over like 10, 11 years that this guideline came out in 2014. And as soon as it came out, it brought in a lot of criticism because there was a lot of controversy about what was in the guideline. The panel of physicians which are on the guideline, it was a mixed panel. About 4 of them were nephrologists, 5 cardiologists, some general practitioners or family practice guys. It was a mix of different physicians who all had expertise in hypertension. 5 of those guys had withdrawn their authorship from the final publication because they did not support what was in the guideline. And these guidelines are supported by NLBI, and even they did not endorse the final version of the guideline. So what is the controversy behind JNC 8, and why is hypertension becoming a tension in the society? And there have been calls to retract the guidelines and make it different. So the task today is to try and understand what was it that was so bad about these guidelines, and is it really true, and do we really need to be concerned and worry about these changes? So there was a big shift in the entire process by which the JNC 7 and versus JNC 8, in which they approached the process of developing a guideline. And a majority, the big change that came in was because the Institute of Medicine recognizing that the leaders or the people who are in the position of putting out these guidelines really have to look at the best available data and then make those decisions based on that data. JNC 7 in their recommendations took into account a lot of studies, including some observational studies, some meta-analysis, when they came up with their recommendations. And those recommendations were not graded based on the strength of evidence that was available for those guidelines. So a majority of those guidelines that were put out by JNC 7 were what you would call opinion-based in today's day and world, when you would really want to classify them into the strength of evidence that was available. JNC 8 took away from that and made a point to only look at randomized controlled trials, and not only the randomized controlled trials of any magnitude, but graded those randomized controlled trials into good quality or poor quality, had to have certain minimum number of people in that trial, and had to have very well predefined outcomes of that trial. If the trial was done as a primary target of reduction of proteinuria, that was not included as a valid basis for inclusion for hypertension management outcomes. So they really wanted to look at trials with defined primary endpoints and come up with recommendations. And they did come up with graded recommendations and put out the answers for 3 specific questions that they tried to identify. The number 1 question was, when do we start hypertensive therapies in variety of population that is out there? What should be the goal of the therapy once you decide to start hypertensive treatment? What should be the goal of that therapy, or what should be the blood pressure goal? And then, do we do this with drug A versus drug B? And is there evidence to support that one drug is better than the other? So that was the task cut out. So 3 simple questions that we set out to answer, and yet we had so much opposition and lack of consensus that 14 specialists who are gurus of hypertension were not able to come on and think. So this is the process of JNC 8. They looked at studies all the way from 1966 till 2013. The initial process was to look at studies till 2009, but because of the delay in the whole process by which in 2011 is when Institute of Medicine came up with their recommendations for changing the way by which we put out these guidelines. They had to redo the whole document, and then they included the studies up until 2013. They excluded anything with less than 100 patients, as I said, and the follow period of less than 1 year was also excluded. So, and they rated each randomized controlled trial as a good or a fair study, and only those were included into their analysis. And these were the primary endpoints because of hypertension that they looked at. So all the major cardiovascular endpoints were included into the analysis. And these are the 9 recommendations that are now out from JNC 8. And the ones that have created the most controversy is the recommendation 1, which states for people older than 60, the goal blood pressure should be less than 150 by 90. This is a strong recommendation and has a grade A value to it, telling me that it's coming from well done randomized control studies which showed that the evidence is there that you need to move the target blood pressure control from 140 to 150 systolic for patients who are above the age of 60. The second and the third were for patients below the age of 60. There was no change in the recommendations, and the target blood pressure for somebody who's under the age of 60 with hypertension remains at 140 by 90. There was also a change in the CKD patients. The JNC 7 had clearly said that all CKD patients, the blood pressure goal should be 130 by 80. We changed this in this recommendation to 140 by 90. Diabetic patients, a similar change, went up from 130 by 80 up to 140 by 90. And you notice both of these were put out as expert opinion as the strength of evidence. And the way they were able to say that this was a strong recommendation or an expert opinion was based on how many of those panel members agreed on that particular recommendation. If only less than 2/3 of the panel agreed on that recommendation, that was put out as an expert opinion. And the level of evidence is grade E because it's opinion based. The initial recommendation also has in terms of what therapy should you pick up as the initial therapy, has also come under some scrutiny because they did make some recommendation based on the race of the patient that you're treating on. So let's go over these guidelines and try and see, what is that led them to come up with these recommendations. So over the next 30 minutes or so, I'm going to go over some of the studies that they looked at, which they felt showed the evidence to make up these changes. So the first recommendation, which is a strong A, grade 1, came from majority these 3 trials. The HYVIT trial, about 4,000 patients, randomized patients into thiazide diuretic indapamide once a day. And if your blood pressure was not in target and the target there was less than 150 systolic, that was the target, then you would add prendilopril, an ACE inhibitor, and you would get those patients to below 150 systolic. All the patients in that HYVIT trial were above the age of 80. So that's something to remember because that has been put out as one of the criticism for JNC 8, And then people have stated that the evidence is extremely clear for the patients above 80. There is no controversy that the goal is okay to be above 150 systolic. And that's primarily based on HIVIT, which showed a 21% reduction in death, statistically significant, and an all-cause, all-stroke reduction, which includes fatal and non-fatal strokes, by 30%, which was also statistically significant. The two other trials that have looked at mortality and benefit of blood pressure treatment included patients above the age of 60. First was the Systolic Hypertension in elderly population trial. Again, 4,000 plus patients. They also used chlorthalidone as their first agent and then added atenolol or resipine as an add-on agents for blood pressure control. Showed a reduction which was statistically significant for all-cause strokes. And the European trial, which was able to mirror the same outcome. All of these trials use 150 as a target blood pressure for treatment. So 3 trials all showed benefit. And within a month of the initial publication of the JNC 8, the 5 people which did not agree with the panel's recommendation put out this commentary on Annals of Internal Medicine, stating that there may be evidence that the goal blood pressure for people above the age of 60 should be below 150. And they worded it as that, and they wrote the article mainly because they wanted to put out that there may be evidence, and we really need to be careful about raising that bar up, because by doing so, we may be exposing some of the high-risk patients to a higher blood pressure, and maybe that will negate some of the benefits that we've made over the years in reducing the mortality or morbidity by lowering these blood pressures. So why did despite these 5 people on the thing, the rest of the panel felt that there is evidence that if you lower the blood pressure below 140 in patients who are above the age of 65 or above the age of 70, and there were 2 trials that did precisely that, to look at the target blood pressure below 140 versus below 150. And they were able to get the blood pressures below 140 in both these trials versus below 150 in the control group. It showed no difference in cardiovascular death, no difference in strokes, and there was a non-significant decrease in death in only one of these trials. And these are big trials. The JATO study was done predominantly in Japan, so there's been some criticism about that. This study may be not relevant to the patient population that we have in the United States. There was no significant, but one other criticism that has been raised about these 2 trials is that the total number of events in both these trials was extremely small. So even though they had 4,000 plus patients in both the trials, the number of events was extremely small. The primary endpoints was extremely small in these 2 trials. So if you compare it to the other trials, not as much morbidity was seen in these 2 patient populations. So here's what the panel had put out as a thought beside for lowering it to 140 or keeping the target at 140, because there have been some meta-analysis, including some not so randomized controlled trials which have shown benefit with blood pressures of less than 140. About 30% of the patients who were in the ALLHAT trial were above the age of 60 and had shown benefit with reduction of blood pressure. But that was again a post hoc analysis. It was not the primary endpoint of ALLHAT study. So that's why they did not include that study in that evaluation. And then they also said that there is also concern that by lowering blood pressure too low in elderly population, you may expose them to a higher side effect that may be seen. Both JATOS and VALISH did not show that there was a higher adverse events in patients when the blood pressure was lowered to 140 versus 150 target. So that's why the controversy remains out there. There were several patients, as I mentioned, in the ALLHAT group, the ACCOMPLISH trial, and the VALUE trial, which had shown that the blood pressure of less than 140 in the patients between the age of 60 and 80 can benefit from a lowered blood pressure threshold. And then there's the speed limit effect, right? They worry about that if you raise the bar to 150, then you're going to drive to 160, because we all do that. If the speed limit is 60, 70 is always okay to drive to. So facing that opposition, they did come up with a corollary recommendation in that recommendation 1, which basically said that if you have a current patient who is in your clinic, who's 65 years of age, and his blood pressure is doing well at 142 or 140, you do not need to cut back his medications and raise the blood pressure up to 150. It's okay to watch them with the blood pressure of 140, but what they said was that the evidence may not be there to lower somebody down to 140 systolic blood pressure. So this was put out as an expert opinion, because that was not something that the entire panel agreed on. If you look at the recommendation 2 and 3, I'm not going to go into the details on that, but I just wanted to put out that these were based on placebo-controlled trials, which I think will be unethical to do in today's day and age. It's remarkable that they were able to show that when you treat these patients, the total amount of the trial endpoints is lowered remarkably. The mortality is significantly less than half the mortality that you see. And the VA cooperative trial was the very first trial done in 1970s that was able to demonstrate that by lowering the blood pressure down in patients with diastolic blood pressures of more than 90, there would be significant improvement in death. So even at that point, the VA cooperative trial in 1970s emphasized this little statement that is still really relevant, that there is a need for greater professional as well as public education concerning hypertension, and I think that's what we're trying to do today. So let's look at recommendation 4, which was precisely for patients with CKD and hypertension, which is pretty much all the patients that I see, and a majority of the patients that are seen in the medicine clinic as well. So there was a shift from patients' blood pressure goal, which was less than 130 by 80, and that's what we have taught and have been taught to date, to a goal of less than 140 by 90. So what made us change this goal? So we look at the evidence based on, again, the randomized controlled trials, which we think is the gold standard to answer this question. So one of the biggest studies done, again, back in 1980s and 90s was the MDRD study, where they recruited patients with a GFR between 15 to 55, and they subjected these patients into 2 different blood pressure groups, the low and the high blood pressure group. And the mean arterial blood pressure in the low group would put the patient's blood pressure at about 130 by 80 versus 140 by 90. And if you look at the rate of decline in GFR, there was a faster decline in the group that was with the lower blood pressure initially, and then the slope kind of leveled off. But at the end of the day, and a 3-year follow-up, there was very little difference between the 2 groups in terms of the outcomes. If you look at the primary endpoint or composite endpoint of ESRD or death, again, there was no difference between the 2 groups in terms of the primary endpoint of composite of death or ESRD. But if you break the MDRD study into the patients who had less than 1 gram of proteinuria, 1 to 3 grams of proteinuria, and more than 3 grams of proteinuria, and then looked at what was the benefit in those patients. In patients who had less than 1 gram of proteinuria, both the low group and the normal blood pressure group had no difference in the rate of drop of their GFR, which was about 3 ml per year drop of GFR. If you had higher proteinuria, 1 to 3 grams, patients in the lower blood pressure group had a little less drop in GFR as compared to the ones who were in the higher blood pressure group. But if you had 3 grams of proteinuria, the difference was even more significant. So within that study, but again, this was not the primary outcome of that study. They did not look to stratify the patients at the outset into different proteinuria groups to look at and answer that question. They were only trying to answer that in the broad CKD population, would there be any benefit of dropping the blood pressure to 130 by 80? And the broad answer for MDRD was no. But perhaps with some probable benefit in patients who had higher proteinuria. These patients were followed up at the end of the study, and they had a 6-month follow-up appointment. And all the patients who were in the lower blood pressure group, they stayed low even at 6 months follow-up. So perhaps these patients had learned and been on the same medication, so the blood pressures did not really change, and the mean arterial blood pressure was low. So if you follow these patients 10 years later and see what happened, patients who were in the low blood pressure group as compared to the high blood pressure group had a better kidney survival long-term over 10 years. That again was not the primary endpoint of the study, so that's why it was not included in the JNC 8th analysis. African American subgroup is known to have higher blood pressures and a rapid decline in GFR. So do we have any evidence that lowering blood pressure in the African American subgroups works better to lower it to 130 by 80? And that was precisely the answer that they tried to answer with the ASK trial, where they had a 3x2 factorial design because they also wanted to see if the ACE inhibitors compared to the calcium channel blockers would have preferential benefit in patients with CKD. And they also wanted to answer whether 130 by 80 would be a better blood pressure control. So if you look at these patients, all of these patients had proteinuria of above 300 milligrams a day minimum. So a similar story came out. The patients who were in the usual blood pressure group, the lower blood pressure group, as soon as you started them on the low blood pressure threshold, they had a rapid decline in the GFR, which stabilized after a while. But then the slope of GFR change between the two groups was no statistically different. The total at the end of the study, the lower blood pressure group had a slope of 2.11, or total decline of 2.11 ml per minute per year compared to 2.32 ml per minute per year in the patients who were in the usual blood pressure group of 140 by 90. So again, the study failed to show the primary endpoint that lowering the blood pressure to 130 by 80 in CKD patients, African Americans, does you any benefit, even by using ACE inhibitors as a primary group. But if you break down the study and you look at what happened to the proteinuria, the patients who had the usual blood pressure group, over the course of 4 years, the proteinuria went up by 7%. But the patients who had the lower blood pressure group targets, the proteinuria went down by 17%. So perhaps, again, a suggestion that there is benefit, but it did not show, it did not pan out to be as a primary endpoint that they achieved. And is there any benefit of proteinuria reduction? That's a question still out there. The RAIN trial was done primarily for patients who had non-diabetic proteinuria, and the goal was to try and study what is the benefit of ACE inhibitors versus placebo in reducing their blood pressure. So patients who were put on ACE inhibitors were compared to patients who were put on calcium channel blockers. The blood pressures were equal in the two groups, and it was clearly shown in the RAIN-1 study that the patients who had proteinuria benefited from ACE inhibitor, and the higher the proteinuria, 7 grams, the benefit was even more remarkable. The rate of decline of GFR was much higher if you were not on ramipril versus if you were on ramipril. So ACE inhibitors and that study and several other studies clearly show the benefit of using ACE in patients with CKD and proteinuria. But then the RAIN-2 study was designed. The RAIN-1 study, the diastolic target was 90 millimeters of mercury. The RAIN-2 was designed that if we lower it further to 80 millimeters of mercury, would we have any further benefit, and would we be able to have any other outcome? Another thing that another question that was out there was, then the MDRD study, about half the patients who were in the low blood pressure group were also taking ACE inhibitors. So perhaps that would have negated the benefit of the lower blood pressure in terms of what will be the rate of decline, because ACE inhibitors would be protective in the rate of decline. So the RAIN-2 trial stratified these patients into ACE versus the conventional blood pressure control, which was 140 by 90, versus the intensified blood pressure control 130/80, it showed no difference in the primary outcome of ESRD over a follow-up of about 5 years. So again, no change in the cumulative incidence of ESRD, rate of GFR decline, or residual proteinuria. So we've got 3 main studies which showed that if you try to take CKD patients and you put them on a lower blood pressure goal of 130/80, that you would have a clear benefit of delaying ESRD, improving the renal function, or delaying the rate of GFR decline, or improving the outcomes on kidney. So this is a summary of the 3 studies. The primary outcome, which was the rate of or the degree of decline in GFR, was no benefit was not different in any of the 3 groups. And all 3 of these studies had primarily CKD 3 to CKD 4 patients in that subgroup that they looked at for CKD and the benefit of blood pressure reduction. So JNC 8, based on those 3 studies, came up with this recommendation of 140/90. KDIGO and some of the criticism for JNC 8 has been that there is some evidence that if you dissect these population of CKD into the patients who have proteinuria versus no proteinuria, perhaps there is benefit to lowering the blood pressure down to 130/80 in patients who have proteinuria above 300 milligrams or half a gram a day. And we should give them that benefit versus patients who have no proteinuria. So if I have my CKD patient who's got a GFR of 45 today and he's got no proteinuria, I can very firmly say there is absolutely no evidence that there is any benefit of lowering that patient to 130/80. But if I have a patient who's got half a gram proteinuria or certainly 2 grams proteinuria, I would not be on firm grounds to say that the loading to 130/80 is not beneficial. So perhaps there is some benefit for lowering that blood pressure to 130/80 if you had proteinuria above half a gram or a gram a day. The recommendation 5 was for diabetic patients, patients who have diabetes. The goal has been 140. The goal has been less than 130/80 as of JNC 7, but now we are changing that to say in patients who have diabetes and do not have CKD with heavy proteinuria or do not have any other comorbid conditions, the blood pressure goal should be less than 140/90. So where did we come with this? Where did we come from this? This came from the UK-PDS study, a large randomized controlled trial, again looking at a lower blood pressure to below 150/85, and the achieved blood pressure goal was 140/82 versus 154/87 with more aggressive versus the less aggressive therapy. It showed that there was a 24% reduction in both fatal and non-fatal outcomes, and both the macrovascular and the microvascular complications were better in diabetics when the blood pressure was lowered down. So 144/82 was the mean blood pressure at which the most benefit was seen. And if you trace the drop in both the myocardial infarctions, which are in the boxes, there was significant drop, and also the microvascular endpoints were also less in patients once you drop the blood pressure down to 140/90. But they also saw that, which was not the primary endpoint, that as the progressive blood pressure went down, there was some benefit in patients in terms of a lower morbidity with both myocardial infarction and with the microvascular endpoints. So what is the evidence that urged JNC 7 to put the target at 130/80? And that came from the HEART trial, again a multi-center trial done over 26 countries. And their primary goal was to try and see that if you would take diastolic blood pressures and randomize your diabetic patients into diastolic blood pressure of less than 90, less than 85, and less than 80, and you would follow them over a span of time, would you have a benefit in the less than 80 subgroup versus the patients who were in the less than 90 subgroup? And the short answer is that there was no benefit in the overall study on 130/80 versus in patients who had 80 or less systolic blood pressure, or patients who have more than less than 90 blood pressure. And there were a few criticism about this study. So let's kind of break it down. So this is what the study was overall. Let me see, go back here. Let me go to the next slide here. Okay. So if you looked at the overall study results, these were the study results. In patients in the entire subgroup, which was about 18,000 patients in the entire subgroup, and 6,000 were less than 90, 6,000 were less than 85, and 6,000 were less than 80. And you looked at 90 versus the 80 subgroup, the major cardiovascular endpoints, all stroke, cardiovascular mortality, and the total mortality was no different. Okay? So these are all comers. Sorry, did I say diabetics? These are non-diabetic. These are all comers in the study who had hypertension, and we stratified them according to the drop in their diastolic blood pressure. But if you took a subgroup of patients within this population who were diabetic, and this was again not the primary target or the primary endpoint of the study. So if you do a sub-hoc analysis of that population of the HEART trial and only looked at the diabetic patients, there was benefit when you would compare patients with 90 versus an 80 diastolic blood pressure, 90 versus 80. The stroke was better, cardiovascular mortality was better, and the total mortality was better. But because this was an ad hoc analysis post-study, this was not included in the JNC 8 analysis and was put out as inferior study, which was not be considered in the final recommendations of JNC 8. And then we had recently the ACCORD trial, but the ACCORD did not, and then they tried to look at the systolic blood pressures of less than 120 versus less than 140, and a lot of patients, 10,000 patients, type 2 diabetics, and there were 3 trial arms with glycemic control, blood pressure, and lipids. But there was a very nice separation between the patients who had blood pressure target of less than 140 versus less than 120, and these patients were followed for about 7 or 8 years. And if you look at the primary outcome of non-fatal MI, stroke, or death, there was no significant difference between the two groups. There was a significant drop in the number of strokes in the patients who had a blood pressure of less than 120. So if you look at the significance of the total endpoints, mortality, 150 events versus 144, so little higher death in patients who were at 120 blood group. Cardiovascular deaths, no change, maybe a little higher death in patients who were at 120 blood pressure group. Non-fatal MI, again no difference. Non-fatal stroke, no difference significantly. The only difference was in the total strokes, which was significantly less in the patients who had 120 blood group. Yeah, fatal stroke was significant. Right? So that was the only difference in the two groups in terms of the benefit of the two drugs. If you look at the serious side effects, the intensive group, 3.3% side effects versus the standard group, which had 1.3% side effects. Hypotension, way more common in the intensive group, which is understandable. But the rest of the side effects were no difference. But if you look at the rate of change of eGFR, which is what I would look at, it was much higher in the patients who were in the intensive blood pressure control group versus the 140 blood pressure group. So certainly we have evidence that 120 blood pressure is not the target for diabetic patients for sure. The question still remains out there that maybe is 130 systolic blood group, would that have clearly shown any benefit versus 140 blood group? And there was another study that I want to mention that was not included in JNC 8 analysis, which was the ADVANCE trial. And the reason they did not include ADVANCE in the final analysis of JNC 8 was because this was an open-ended study. The inclusion criteria did not require you to be a hypertensive. So they took all diabetic patients who had hypertension or did not have hypertension and put them into a staged ACE inhibitor, and what they're looking at is, will ACE inhibitors decrease the composite of primary endpoint? And they looked at several endpoints, including mortality. There was a difference in blood pressures in patients who were put on the medications versus those who were not. So 140 versus 134. The diastolic blood pressures overall mean was not a big difference. And they did show a relative risk reduction of 14% in overall deaths that was seen in that population. There was also benefit in patients who were put on the ACE inhibitors early on, before they even developed hypertension, in about 1/3 of the population, and then 2/3 of the population had low-grade hypertension. The new patients developing microalbuminuria were much less in patients who were put on the ACE inhibitor plus thiazide combination in about 10,000 of the patients. So again, there may be evidence that lowering it to 130 systolic blood pressure may be beneficial in diabetic patients, but this study was not included in the JNC 8th analysis because it did not meet the criteria, the inclusion criteria that they required for their analysis. And this was the all-cause mortality, which was lower. The coronary events was lower, and this was irrespective of their initial blood pressure. But the patients were included irrespective of their initial blood pressure levels, and about 2/3 of the patients had hypertension, which were included into the study. So why do we worry about lowering the target so low? Because I think we worry about the cost, we worry about the risk of side effects, we worry about monitoring that is required. The patients may need to be seen much more closely. And then you worry about potential of increased mortality that was seen in the core trial, and you worry about the J point or the J curve of hypertension mortality, where lowering the blood pressure below a certain threshold may decrease your coronary perfusion, may decrease your overall longevity, and you may not be giving those patients the benefit. So we went over this. The third question that was raised was, I'm just going to skip this. What about which drug are you going to use to treat your patient with hypertension? And is there any benefit of A drug versus B drug? And is there any difference between patients who are African Americans or the black population versus the non-black population? JNC 8 did give some recommendations. So let's walk through and see how did they come up with those recommendations. They did say that the alpha blockers are not recommended as a first-line agent, and they based that primarily on the ALLHAT trial, which had clearly shown that patients in the ALLHAT study who were on the doxazosin arm, which was about 1/4 of the total study population, that arm of the study was ended prematurely because of a significant, no difference in mortality, but when you looked at the cardiovascular outcomes, which was significantly higher in the patients who were in the doxazosin, congestive heart failure significantly higher in the doxazosin versus the rest of the population. And then when you looked at patients who were African American versus non-African American, doxazosin did badly in both the groups, both with CHF and in combined cardiovascular mortality. The doxazosin had poor outcomes as compared to the rest of the study population. So very clear evidence that when your patient comes in with hypertension, you don't start them on terazosin or an alpha blocker as the first-line agent. The second drug that they did not include into their primary management strategy was beta blocker. And the evidence comes from predominantly the LIFE study, which looked at losartan versus atenolol. The reason they chose atenolol as a representative beta blocker was because it was the most commonly used beta blocker for hypertension control, has a long half-life, and is usually the first choice agent when you're treating hypertension predominantly. So again, an elderly population, 55 to 80, and the mean blood pressures between the two were comparable, and you follow these patients for a while, the stroke was the predominant thing that was different in the patients who were getting losartan, had a much lower incidence of stroke, about 25% lower risk of stroke as compared to patients who were on atenolol. So a 25% reduction of stroke in 5 years led them to suggest that beta blockers should not be the first-line agent for treating hypertension. If you look at the life study and in patients who had prior myocardial infarction or patients who had an MI, atenolol actually did better in preventing acute MI. So we are not asking the question which drug is better for secondary prophylaxis. I think we're looking for primary prophylaxis against MIs or all-cause mortality or stroke, which drug would be better. So certainly between atenolol and losartan was proved to be better. And they also compared the side effect profile in the life study. The drug-related side effects were significantly higher in the patients who were on beta blockers versus the angiotensin receptor blocker. So again, a suggestion that the beta blocker, because of the side effect profile and also an added increased risk of stroke, should not be the first-line agent. Let's kind of walk through the ALLHAT study because that's where the guidelines specify that you use chlorthalidone as a thiazide or the calcium channel blocker or lisinopril in Caucasian population as your first-line agent or in the non-black population. Because when they compared these agents, the cardiovascular or the coronary heart disease was pretty much no difference between the three agents. It was about the same. The mortality, pretty much no difference between the same. Stroke, maybe perhaps a little higher risk of stroke in patients who were on lisinopril, but we'll break it down in a minute. CHF, a little higher in patients who were on amlodipine versus chlorthalidone, and in patients who are on lisinopril versus chlorthalidone. But if you break down the ALLHAT population into the African American versus the black versus the non-black population, the black population on lisinopril had much poor blood pressure control as compared to patients who were on amlodipine. Patients who were on amlodipine, the black patients had very poor blood pressure as compared to those who were on lisinopril. Okay? So lisinopril, poor blood pressure control, amlodipine did better. But in non-black population, both lisinopril and amlodipine in this black boxes here did about the same. So the overall blood pressure difference, and this is the complete study, but if you look at the black population and compare the baseline blood pressures, no difference. But when you compare the 6 years, the 2-year blood pressure difference between the two groups, lisinopril, the average blood pressure was 143 versus chlorthalidone and amlodipine 139. So there was significant difference between the blood pressures in the group that was on lisinopril versus chlorthalidone, suggesting that perhaps chlorthalidone and calcium channel blockers are better in African Americans in lowering their blood pressure. When you looked at the non-black population, all three drugs were equally the same, and there was not a big difference between which drug did better. There was perhaps a suggestion that lisinopril actually did better in the non-black population. Why is it so? There have been several theories put out as to why would African Americans respond better to diuretic group of medications. And one of the main things that have been put out is the sodium sensitivity, which may be higher in the African American groups, and they may be more volume-dependent blood pressure patients versus the non-black patients who may not be volume-dependent, and their blood pressure may be driven more by hormonal increase that drives their blood pressure. So when we break it down in terms of benefit, there was clear benefit that patients who had, in the African American patients, chlorthalidone versus lisinopril, chlorthalidone did better both with ESRD, heart failure, and stroke, as well as a combined cardiovascular disease. So based on these data from the ALLHAT trial, which is to date the biggest study in hypertension in terms of which drug will have benefit, they said the non-black population, thiazide, ACE, ARB, or calcium channel blocker can be chosen any one of them. Whereas perhaps in the black patients, you may want to use a thiazide or a calcium channel blocker as the initial drug because it does comparatively have a better outcome as compared to ACE inhibitors or ARBs. And you certainly don't want to use beta blocker as an agent. I just wanted to put this out too, that there is clear evidence that using a combination of ACE and ARB is definitely detrimental. There was higher risk of side effects, higher renal dysfunction, statistically significant, and possibly also a higher death rate, which was not, there was a trend towards a higher death rate in patients who were put on a combination of ACE and ARB in a predominant patient population which had vascular disease or high-risk diabetic patient population. So unless there is a very clear indication, which is in patients who had significantly uncontrolled proteinuria and anasarca, we should not put these patients routinely on an ACE and ARB combination. The JNC 9 recommendation is something that everybody agrees on, so I put that last. That the main objective of the hypertension treatment is to attain goal and maintain the blood pressure at goal. You should increase the dose and then titrate and add a second medication if your blood pressure does not get at goal. And you need to continue to assess the blood pressure routinely and then convince your patients about compliance and monitoring their blood pressure is an important thing. Then you need to add medications if your blood pressure is not controlled. I was in India just recently and I was looking up the control of hypertension in India, and I came across this picture. Brad Pitt posing for a commercial for a tobacco product, for an oral tobacco product. And I was kind of surprised, like, why would Brad Pitt want to do this? And this is like a small company that makes chewing tobacco in India. And then when you started looking at it, and it came in from Faking News, that's a study. The author is Idiot 420. So good news, the good old investigative journalism still works, and I think we really still need to stick with evidence-based medicine to try and find answers for what we need to do. So everything that you see on paper may not always be true. You really have to go back and find the answers yourself. And then when you look at the history of randomized controlled trials, we've been doing them for a long time. And if you look at a general thing, we've had over 400,000 randomized controlled trials to date. And we need them because the healthcare is constantly changing. Our targets are moving, and as we have better medications, we need to constantly test our knowledge today. And as we saw at the start of the lecture, we've come a long way from 1930s to now in terms of understanding hypertension. But I think that's an ongoing process, and we need to keep looking at newer innovations and coming up with better targets. So those are the recommendations now, and perhaps one day we'll have grade A evidence for all of these recommendations. But this is the best we have today, and hopefully some of these will be answered in future. There's a trial ongoing in specifically looking to drop the blood pressures to 120 by 140 in general population. And again, so I think there's several of these trials that are ongoing which are trying to answer these questions again in the general population, and I think we always look for better answers for the questions that we have. I think with that I'm going to end, and I'll take any questions that you have.
How about the patient who's black and diabetic? What do you add first, and then in what order do you add it?
So an African American patient who is diabetic, so if he's got, again, no proteinuria, the current evidence suggests that his goal is 140 by 90. And then you could take any of those two recommended medications. The question that you pose is a difficult question because there is no evidence there which has looked at particularly ACE inhibitors in diabetic patients as to whether there would be particular benefit with those patients. So my practice is to make sure that they get to goal. I would start them on an ACE inhibitor if they have any microalbuminuria. If they don't have microalbuminuria, then I tend to put them on either a thiazide or a calcium channel blocker as my first agent.
So if they've got proteinuria, you start with the ACE and then add the diuretic.
As an add-on to get them to below that threshold goal.
I have a question about the methods of these huge studies. did they control for adherence? And then when you measure blood pressure, I mean, it's like, was that 1 or 2 readings every 3 months, every 4 months, every year? I mean,
so most of these randomized controlled trials, they've had a very clear protocol that they would put out, and not going into the details of every trial. But the usual protocol is usually office blood pressure measurements at a pre-specified time, which can vary from one study which would do it every month to another study which would do it every 2 months. So different, I did not go into the details of which study looked into that way. They all have had some of those studies have looked at adherence or blood pressure control in terms of having pill counts or ways to monitor or administration of pills. But we all know that compliance with medications is a challenge. And my patient in general clinic may not have about 50% compliance with a hypertensive medication. So I think that's a constant challenge. I think knowing what they do in randomized trials, if they have a close monitoring, we can all hope that the data is as pure as we think it is. And we have to rely on what is available to us as of now.
Yeah, my concern was sometimes I think residents add a medicine without checking on adherence. I mean, the blood pressure is not controlled that visit.
Absolutely. So I think whenever you have resistant hypertension, my number one thing is compliance. And my number two thing is to pick up the phone and call the pharmacy as to when was it last filled. And we all surprised more than half the times that the medicine was never filled. So I think that, you know, we have to have means and means in terms of addressing what is resistant and not resistant. And then we really have to figure out, you know, what can you do about impressing to their patient that this control is really important. So one thing I advocate to all my hypertension patients is that hypertension is never going to go away. You have it now and you're going to die with it. So this is a disease which is long-term. Take ownership and find a way to measure it at home yourself. And if they start doing it, their compliance with medications does go up. But that does require constant, you know, pressing on them to get to that level.
There seems to be much more emphasis in JNC 9 on chlorthalidone than
Yes.
Okay. Is there a recommendation of chlorthalidone versus HCTZ?
Very good question. I think so. Chlorthalidone seems to be a medication which has been kind of forgotten. And if we looked at all the studies that I showed, I don't think I showed any study which had hydrochlorothiazide as the agent of choice. It's something that we've gotten so used to. We use it over the years, and we trained with it. So we've gotten really comfortable using it. And if you look at the pharmacokinetics of hydrochlorothiazide versus chlorthalidone, chlorthalidone definitely has a much higher half-life and a longer duration of action. So hydrochlorothiazide perhaps is a BID drug, but it's used commonly as a QD. So yes, wherever possible, I would start using chlorthalidone as an agent which has been shown to have better outcomes. There is no head-to-head trial which has compared chlorthalidone with hydrochlorothiazide and long-term outcomes on those patients. Yes.
Is there any role for invasive methods of blood pressure control like denervation of the heart?
So hopefully by JNC 9 we'll have that. But there was a lot of enthusiasm with renal nerve ablation. And some of the initial studies, 2 studies, one of them was a randomized controlled study which had done renal nerve ablations in a group of patients with resistant hypertension. Anybody with more than 3 blood pressure medications and they were still not in control, or the blood pressure was above 160 systolic, were subjected to renal nerve sympathetic ablation, which can be done with minimally invasive technique now. And the studies did show benefit initially, but then a large randomized controlled trial which was published, I think that was the Medtronic groups, which showed absolutely no benefit with the patients who got the nerve ablations versus the nerve ablation. So I think we are getting there. There were problems with the device that was used for nerve ablation in that last study. They have modified that device because you can get a much better 360 circumferential nerve ablation now with the new product. And they are contemplating more studies with that. So as of the short answer today, yes, no, there is no evidence today. but historically that was the treatment of choice back in 1950s when they contemplated doing renal nerve ablation in President Roosevelt when his blood pressure was found to be 200, but then he refused the surgery, so that it was never done. So, but there is historical evidence that sympathetic me does decrease blood pressure, and we know that because it controls renin secretion. And hopefully we'll get some more evidence soon as to whether we can do it non-invasively or minimally invasive procedure. Just talk about it.
Two historical comments. Chlorthalidone has been used primarily by the British. The ALLHAT study was in Britain. I don't think that makes chlorthalidone a better drug.
Well, I think it's definitely a more potent thiazide.
Yeah, but we have used hydrochlorothiazide effectively in the United States. The other is atenolol is probably one of the poorest beta blockers we have. Its range of action is not 24 hours, so it goes one time a day. I think the more definitive studies will come when we use the later beta blockers.
No, I totally agree with you that maybe the more newer agents with both alpha and beta blocking capabilities may have better efficacy at blood pressure control. But I think one of the things still stays with beta blockers. The side effect profile for beta blockers is definitely much worse than compared to some of the other newer agents.
I'm not against.
No, I agree. But I think what you're saying is if you have a treatment naive patient who's never had any therapy, especially the younger patient, I would probably never use beta blocker as the first line agent because of the risk of sexual side effects, exercise intolerance, metabolic side effects, which you have none of those with an ACE inhibitor, except for that small risk of angioedema, which you would monitor for in the early days of therapy. So I think you have much safer alternatives with less side effects, and that should always be kept into mind whenever you pick up a new medicine on anybody.
So I just would not like to see us return to a atenolol only.
No, certainly in patients where there is a question of secondary prophylaxis and patient has history of CAD or MI, those medications are absolutely indicated. But we're not talking about those. We're talking about patients who've got no prior history, no medications in the past, no comorbid conditions. What medicine do we choose as a first line agent?
So if you have a patient who's 65, blood pressure of 150 or 90, should we treat? Or should we just let it go?
Again, there is mixed evidence there. Depends on which side of the panel were you in, were you on left or right. So the left panel would say, no, just watch. 150 or 90 is the target blood pressure. And if you're at that point, you don't need to treat because the benefit is not there.
Is there any harm? I don't think there's any harm.
There is harm. Well, I agree. The JTOS and the VALISH both said that there was minimal harm with the two studies if you dropped it to below 140. But if you dropped it below 120, ACCORD clearly showed that there is harm. So you have to be careful. Right. So I think that the debate lies between that 130, 140 blood pressure as to should we drop them to that 140 or below group, and is there any benefit? We have not shown any benefit to date, and that's where the challenge lies. So perhaps we need another study to answer your question clearly. If you believe the Japanese study, no, there is no benefit.
I think the point is there is no harm. If you have a patient, I think...
No, the harm, whenever we say no harm, there is harm of drug cost. But, and that's why they gave that corollary recommendation.
No, I'm talking about dry patient who has never been on treatment.
What about the cost of medication? What about the cost of care? He's going to come in and get labs drawn. All of that is adding to the cost. But if you didn't treat him, you didn't need to do anything.
Yeah, but that applies. That's what we do in the clinic. Just take time.
Thank you, everybody. Thank you.